Our next speaker is joining us virtually, and it's a pleasure to welcome him to the conference today. Dr. Firas Zar is a cardiologist at the Oregon Health Sciences University in Portland. He received his medical degree from the Damascus University Faculty of Medicine. He's been in practice for more than 20 years. He has published extensively on transcatheter and structural heart treatments for the tricuspid, the mitral, and the aortic valve, and is a principal investigator in the Intrepid Apollo trial for transcatheter mitral valve repair, which he's going to speak about today.
Yeah, thank you. Thank you so much for having me. And I apologize, I'm doing it virtual, but this does not take away how honored and privileged to be with this group today to talk about transfemoral TMVR option. I have really enjoyed the last few talks talking about mitral regurgitation, residual mitral regurgitation after TEER, and the complex management of those patients. Clearly this is a very highly prevalent disease, and we're only touching the tip of the iceberg when it comes to treating those patients with severe mitral regurgitation. And what we have known from historic data right now is that most of those patients are not being treated. Even those who have a primary indication for surgery are not getting operated on. And as you can see, the older the patients are, the less likely they will get an operation. And for those who do not get an operation, this is a work that my co-residents and I actually did a while back, where we're looking at what happened with those patients who are not operated on. And as you can see, they're not only not doing well, but they're having higher mortality and higher hospitalization. The surgical literature really support mitral valve replacement over repair for ischemic mitral regurgitation. And therefore, we believe that there is room for mitral valve repair as well as mitral valve replacement, severe mitral regurgitation. And why do we need replacement? Well, we just learned from the surgical literature that replacement is better, probably better than repair for ischemic MR. And we've also have learned from the TEER trials that those who are left with more than moderate, maybe mild to moderate, and definitely moderate mitral regurgitation are associated with a worse outcome. And this is true based on degenerative mitral regurgitation as well as functional mitral regurgitation, as we learned from the co-op trial. So I want to start by MAC. And we use mitral annular calcification very loosely. And the reason why I say that, because a lot of us have put in a off-label use SAPIEN device and MAC. A lot of us have put in a transapical devices. But really, I mean, the way that we describe MAC, and I think most of us are familiar with the Guerrero classification, it is a simple classification that is primarily designed for SAPIEN valve and MAC. But as you can see, there's a lot of heterogeneity in MAC that makes it very hard to predict one valve that is going to fit all sort of mitral calcification. This is a patient that you see have significant MAC. The MAC extend on the leaflet. It is pretty complicated if you look at it on the CT. There is dense MAC. Heterogeneous, not enough to put in a balloon expanding valve in the mitral position. And this patient, despite all the MAC, was treated with the Intrepid valve. As you can see, volume score is around 2,500, not 360 degree, not even 270 degree. And I apologize, the slides are a little bit slow on this one, but you see this patient was treated with the Intrepid transfemoral system with very good results. Now, there was touch on ring, and I think most of us believe, as was said before, that rings are very routinely used in surgical mitral valve repair in addition to leaflet resection. This is a patient that had a 33 millimeter Durand ring, complete ring, and that was failed with the residual mitral, with the current mitral regurgitation. Somebody might ask, can you put a balloon expanding valve in this ring? This ring is a little bit too big, as I will show you. and you see the mode of failure where there is a severe flail as well as torrential mitral regurgitation. And I like the comment from Omar about the eccentricity, underestimate the degree of MR. This MR is, severe by all means, and most of us feel that tear in the presence of a complete ring is associated with increased gradient. Therefore, we try to avoid doing that. This is the area and the perimeter of that ring, and as you can see, we got a dimension of around 34.5 millimeter. This is a little bit too big for a balloon expanding valve. Somebody might argue that we can stretch it, and who knows what is the long-term outcome of that. This patient was evaluated from the Intrepid valve. The neo-LVOT was found to be sufficient and with 5.4 centimeters square. And I want to stop here for 1 second to comment about LVOT for TMVR. It is not hidden on anybody that the highest screen fail for TMVR trial of all valves of all sorts is neo-LVOT. And there are multiple reasons for that. One is, the ventricle, the mitral aortic angle sometimes is not favorable, but also the design of the valve and the way that it is right now, most of the valve have completely covered side that regardless of what the anterior leaflet of the mitral valve does, we are at risk of LVOT obstruction from the valve itself. However, we got really sophisticated in terms of addressing the neo-LVOT, doing multiple leaflet modification techniques if needed, but also in predicting what is our neo-LVOT is going to look. And as you can see in this example, we put an Intrepid virtual Intrepid valve in the mitral annulus, and we measured the neo-LVOT, and we felt that it was enough. This patient was treated with a transfemoral TMVR system again, and we were able to achieve good results. So where are we right now? We have published the 30-day outcome of the early feasibility trial, looking at 15 patients at 30 days with the Intrepid valve. And I want to spend a little bit of time looking with you through this data, because I find it extremely interesting what we have done so far. And I put in all those patients who, at this point, crossed to even 1 year, with a total of 30 patients. As you expect from this cohort, it's an older patient population, high surgical risk around 5, STS of 5. Most of those patients are class 3 and 4 heart failure. They have the expected comorbidities, diabetes, hypertension, prior hospitalization, but also the split of mitral regurgitation in this cohort was almost 50-50, where we're treating the primary mitral regurgitation as well as secondary mitral regurgitation. I'm sorry. It is not hidden on anybody that the valve, the sheath size is relatively large at this point. However, despite the early feasibility trial, despite the early experience with the transfemoral TMVR system, the time from the delivery catheter insertion to removal was less than 45 minutes. And that would tell you how comfortable most operators are because of the TEER experience in doing the basic maneuvers that is required to get the valve coaxial to the mitral annulus and deploy those valves. The valve is currently available in 2 sizes, 42 and 48 millimeter. The most commonly used Intrepid valve in the trial, no surprise, is the 48 millimeter valve. Most of those cases, we are ballooning the intraatrial septum prior to valve delivery. We believe that this eased the transition across the intraatrial septum and minimized the damage to the septum. And most of the ASDs has been closed so far. However, as the trial continues and operators get more and more comfortable with those ASDs, we are leaving some of them and more of them open. If we look at the first 15 patients, probably around 90% has their ASD closed. But as we move further along with the trial, less of those patients are getting the ASD closed. Now, what is unique about this technology, and we've learned from the transapical system, that also it is a minimally invasive, but associated with increased morbidity on those patients. The transfemoral options is, as advertised, has a short recovery time. Most of the patients were in the hospital for 4 or 5 days. And more importantly, despite how old and frail they are, the majority of them were discharged home. 87% of the patients were discharged home as opposed to a rehab facility. And it is not hidden on anybody that you cannot do a TMVR trial without having an early embolization. It just so happened that this early embolization was in our site, unfortunately, but we have learned tremendously from it. What we have learned is the Intrepid valve rely on the subvalvular apparatus as well to expand, and this patient has rheumatic changes in the subvalvular apparatus that prevented the self-expanding valve from expanding in place, and eventually resulted in valve migration and operation. This patient survived an operation and was discharged and was alive at 30 days. And those are the outcomes that are associated with this technology so far. You know, mortality is very low. At the 30 patients that were treated, there was 0 mortality. However, you know, still this cohort have about 15 of those patients or 14 of those patients has crossed the 1-year mark. We still have very favorable mortality. Obviously, this is very premature and we need to see more patients and more data and longer follow-up. However, it appeared to be safe in terms of the selection criteria for the patient, but also in terms of procedures and outcome. There was no stroke or TIA. There is a couple myocardial infarction, and those are probably related mainly to air bubble. You know, we learn how to de-air the system. It's a large system, and sometimes if we're not careful, de-airing the system can result in air embolus to the right coronary artery. Procedural complication in terms of vascular complications has been the trend that we have seen so far, and we put our heads together and tried to figure out why we have those procedural complications, vascular complication. Probably multifactorial. One of it is not hidden on anybody. It's a large sheet. It's around 35 French delivery system in the current generation of the Intrepid valve. The newer generation is under development and will drop below 30 French, which is where most interventional cardiologists feel comfortable with even percutaneous access. But also we're learning how to anticoagulate those patients. You know, early on, we were very worried about ischemic events. We were aggressive, heparin, Coumadin, sometimes bridging. You know, some of those patients were discharged home before the INR is therapeutic, were bridged with Lovenox. Since then, we've learned tremendously. We reverse heparin at the end of the procedure. We are very careful with the groin. To date, most of the procedures are done with a cut down on the right femoral vein. This is obviously will change once the sheet gets a little bit smaller, but also the post-op anticoagulation, especially that the majority of the patients have atrial fibrillation, have evolved significantly in the trial. Reoperation, reintervention, extremely low. And as you see, the leaflet thrombosis is also extremely low. And this is probably goes to the balance between anticoagulation and thrombotic and bleeding complications. Rehospitalization for heart failure has been also low for this patient, despite the fact that almost half of them were functional mitral regurgitation. We had no rehospitalization at 30 days and a couple rehospitalization at 1 year for those patients who crossed the 1-year mark. Mitral regurgitation, as expected from this technology, TMVR, pure mitral regurgitation. The majority of the patients, if not all of them, have no mitral regurgitation or trace mitral regurgitation at 30 days, and those results are sustainable to 1 year. Now, we've also known from the transapical options that those results are sustainable to 3 years and beyond. So really, TMVR for those patients who qualify, pure mitral regurgitation. Perivalvular leak, trace, if any. Most of the patients have no perivalvular leak, and this has to do with the mechanism of the anchoring of the Intrepid valve, where it anchors on three row of cleats with the mitral annulus, as well as the way that it expands underneath the valve, where it has multiple touch point with the leaflets and the mitral annulus to prevent perivalvular leak. What is also remarkable in the transfemoral options for those patients is the improvement in New York Heart Class Association. And we've seen it in the TMVR trial. However, what is unique about the transfemoral options is now we only see it, but we also see it early on. At 30 days, you notice the majority of those patients are New York Heart Class 1 and 2. And this is sustainable to up to 1 year. And this probably has to do with the fact that the transfemoral option is associated with less morbidity than the transapical options. A lot of those benefit from New York Heart Class improvement are seen early on. Finally, I wanted to tell you guys where we are in the trial and what is the future of the Intrepid TMVR going to look like. Obviously, the trial's been going on for a few years right now, and it's probably related to the co-opt results came in the middle of the trial, as well as the transfemoral option came in the middle of the trial. So the trial design had to be redesigned to accommodate for this data. The transapical system was in the early phases. However, the early feasibility study of the transfemoral system started in 2020, and now we are in the pivotal trial 2022, and that trial is enrolling in a single arm, mainly transfemoral. Transapical remain an option for those with a transfemoral venous system that is not adequate. However, that is going away as well because most of those patients right now qualify for the transfemoral system from a vein size standpoint. So the trial has picked up enrollment, and right now it's enrolling in the transfemoral system only, primarily, and in the pivotal phase. Now, the way the trial is designed, that there is a primary cohort that include primary and secondary mitral regurgitation, and those patients are going to be treated as a single arm with the TMVR technology. And there is a separate cohort that is the MAC cohort. The case that I showed you before belonged to the MAC cohort, where it's going to evaluate those patients for all-cause mortality and heart failure hospitalization at 1 year, specifically looking at the MAC patient population. And as I said, the transapical approach is right now gone from the Intrepid trial, and all patients are treated with the transfemoral system. At this phase, patients who qualify for TMVR are those who are unsuitable for surgery or TEER. And that has obviously been challenged recently about who's not suitable for TEER. We've seen a couple cases where they belong to the yellow/orange, red, whatever you want to call it, spectrum of color. And those patients probably are best served with TMVR. And this is what the current version of the trial is targeting, those who are unsuitable for TEER. However, future trial will have to consider randomizing against TEER. And I see this happening in the future as the sheet gets better, the sheet size gets smaller, the procedure gets better, and we get more comfortable with it. I do not see a randomized trial against TEER far in the future. I'm hoping that we can see it sometimes in the near future. And again, this is an example of the MAC patients that have been approved to the Apollo trial. This is really dense MAC. The trial and the valve function relatively well so far in the patients with the MAC, with significant MAC. I want to finish with a couple accomplishments. This is our team. We were lucky enough that we celebrated the 300th Intrepid implant. Not for us, obviously, for everybody. It just happened that we have done number 300, and we've also done number 100 of a transfemoral implant. And here in the middle, you see a patient who have an Intrepid in the mitral and as well Intrepid in the tricuspid position. And this is one of our early on patients, has the SD closed and a mechanical aortic valve. And if it's worth anything, this patient does not have a pacemaker. So then, to conclude, the Intrepid pilot study demonstrate promising valve performance with the transapical TMVR out of 3 years right now, with stable valve function and persistent MR reduction, with really minimal, one patient who had more than moderate PVL. The TMVR transfemoral EFS demonstrate high rate of implant success, low mortality, no stroke, near complete elimination of mitral regurgitation, and improved New York Heart Association up to 1 year. And as I showed you, it started early at 30 days. High vascular complication rate in the early experience, and the Apollo pivotal trial is now enrolling patients with moderate to severe mitral regurgitation with or without MAC, with the transfemoral delivery system as the primary access route. We plan geographic and patient population expansion. The first case was done in Europe last month, and Canada already started implanting the transfemoral system as well. Really want to thank you again for inviting me today, and apologies I could not be in person. I would have loved to. Thank you.